Hi, it's Dr. John Raymond Baker, DC. Friday, May the 2nd, and on Fridays usually I do my rant videos where I get things off my chest or talk about pet peeves, and today is no different from that. I wanted to talk about an article I found that was printed in 2011 or published in 2011, and I'll be referring to it, and you'll have to excuse me for reading a bit from it because I haven't memorized the whole thing. But it brought out in me my ongoing pet peeve about guidelines, evidence-based practice, best practices, current medical guidelines, etc., which I feel often don't benefit the patient, don't benefit the clinician, but do benefit insurance companies who have the less is best, meaning if we don't have to pay for something, tell them that's the way to go. If we have to pay for medicine or surgery, we don't want to do that, so tell them to go lose weight or do exercise. Exercise is not the panacea, it's not the cure-all for everything that ails you. It's important, but it's not going to fix every disease or disease process. And too often we see insurance companies and guidelines saying, home exercise program, that's the way to go. So anyway, let's dive into this. The title of the article is Clinical Practitioners Not Adhering to Evidence-Based Guidelines for Osteoarthritis. Now, osteoarthritis basically is also called degenerative disc disorder, DJD. It's the joints worn out for whatever reason. Sometimes it's because of a disease process, an infected joint, but it can be a joint that's lost its proper orientation, its proper biomechanics, and because of the added shear forces on the joint, the inappropriate torsion, now it wears out at an accelerated rate, more than it was supposed to. But anyway, like I say, I don't have a cue card, so I'll have to do it this way. New research found clinicians who care for patients with osteoarthritis are likely not following standard care guidelines that are based on current medical evidence. Researchers noted physicians were prescribing medications for pain and inflammation, oh heavens, or opting for surgical interventions rather than recommending weight loss and/or exercise programs to osteoarthritis patients. Details of this study are available in the January 2011 issue of Arthritis Care and Research, a journal published by Wiley Blackwell on behalf of the American College of Rheumatology. And then they go on. A 2002 report by the World Health Organization estimated osteoarthritis to be the fourth leading cause of years lost to disease. Now they don't really say what they mean. Productive years working or lifespan, anyway, lost to disease. OA disability is quickly becoming a major public health concern, with experts suggesting that by 2020, the number of people OA will double due to growing obesity and the aging of the baby boomer population. And that's kind of assuming that being overweight in and of itself causes osteoarthritis, and that's not true. It's not proven, and it's a fallacious idea. According to the Centers for Disease Control and Prevention, CDC, arthritis and other rheumatic conditions. Now, osteoarthritis is not really the same as rheumatoid arthritis, and whoever wrote that needs to bone up on their rheumatology deal. Cost the U.S. $128 billion for 2003. So in 2003, they're estimating that it cost us $128 billion to deal with OA. 24% increase since 1997. Much of the cost burden in care can be attributed to OA, which accounts for a large volume of surgical procedures involving total joint replacements. And I've sent people out for joint replacements, and it was because their joint was so wore out it was not functioning anymore. And it wasn't something that was going to be fixed by losing weight and doing exercise. In fact, exercise was contraindicated because they could hardly walk. Going farther, Dr. David Hunter from the University of Sydney in Australia and New England Baptist Hospital in Boston, Mass., and colleagues reviewed how standard clinical practice diverges from evidence-based recommendations in the management OA. Quote, we present a potential roadmap for optimizing the quality of OA healthcare for those developing and enforcing policy decisions and for clinicians on the front line of OA management to enact practice change, commented Dr. Hunter. Now, what does that mean? It means that we're trying to insert in the folks who have say-so about whether something is paid for or not by the insurance company, and by influencing those who say what's proper practice and what's not proper practice, that we want them basically to say, you need to go out and exercise and lose some weight, buddy. Now, there's a lot of problems with this. One is, let's say that you're sitting, I'm in the South, I grew up in the South, I know my patients that are hard-working, good old boys. Some were professional football players at some point, or wrestlers, or just were in logging, or all kinds of hard occupations, or were in car wrecks or terrible on-the-job accidents. And if a guy is 6'5", weighs 300, comes to you, says, Doc, I was playing football this weekend, I dove to tackle somebody, and now my knees all swole up, I can't hardly walk, can't work. Can you give me some script for pain and the swelling and stuff? Now, if you really want to get in a fight, I would sit there and say, well, listen, you're fat, you're lazy, get up off your butt, go lose some weight and do some exercise. You probably, if you escape getting your clock cleaned, you're not going to see a Bubba anymore. And I really wouldn't blame him. When I was a boy, medical health care was the only health care. I didn't know anything about chiropractic. And a pill for every ill was the way it went. And you went to a doctor expecting, in fact almost demanding, that you get a script. That you went to them, they figured out what was wrong with you, they gave you a prescription to fix it. That's the way it was then, and pretty much that's the way it is now. And patients that go to MDs or DOs and leave without a prescription often feel like they haven't had a valid transaction, that they've paid for a doctor's visit for nothing. And certainly if you were to say, well, buddy, you just need to lose weight and do some exercise, they will feel like that they've gone to you for nothing. In fact, they go on in this silly document to say current clinical practice does not reflect recommendations based on medical evidence. The authors report, or I can read it like they might say it, the authors report that therapeutic interventions are primarily aimed at reducing pain and improving joint function by using therapies that target symptoms, but do not facilitate improvement in joint structure or long-term betterment of the disease. Okay, if somebody comes in, they say they can't walk, they're hurting so bad, and they've got bad inflammation after an injury to that joint, how are you going to improve structure of the joint if it's worn out other than a total knee replacement? If it's bone on bone, the femur is sitting pretty much on top of the tibia, they're shaking hands with each other, and the meniscus is pretty much gone, and there's instability of the joint, you're not going to get them fixed by saying, well, no pain medicine for you and no anti-inflammatories, and go out there and run on that knee that's worn out. Let's see if we can wear it out completely and cause you a lot more pain. But that's really what these medical guidelines are saying. This best practices, evidence-based practice, whatever the heck you want to call it, it's ludicrous. It's not only ludicrous, but it's doing a disservice to a patient who's looking to you for relief of their disease, for relief of their suffering. You know, I mean, it would be different if what they're selling as far as best practices actually worked. If your joint's worn out and you go running on it, you're going to hurt yourself, you're liable to fall, you're going to do more damage to the joint, and you're probably not going to be able to hardly walk after you do this exercise. But I blame it on the fact that a lot of studies are conducted by insurance companies who don't want to pay anything. They want an outcome to a study that says you don't need surgery, you don't need medication, you just need to have an at-home, home-based exercise program, which won't cost them a penny. And like I say, I've been a doctor since 1989. I've seen a lot of people with bad knees. I've sent people out for knee surgery, knee replacement. The only thing that I would agree with is that there's far too many surgeries, arthroscopic surgeries done on knees, especially of people with osteoarthritis in an elder population, that are useless. When I say useless, they're useless to the patient. They're not useless to the person doing the surgery because they get reimbursed for it. But in a fairly wide study, a double-blind study, in which they used sham surgery, meaning they acted like they were doing the surgery, they cut them open, sewed them back up, but didn't do the surgery, compared with folks that they actually did the arthroscopic surgery on, there was really no difference. The sham surgery, the fake surgery, I'm playing like I'm doing it, but I'm not really doing it surgery, was just as good as the real arthroscopic surgery in releasing and removing, reducing pain, etc. The guidelines they were using, or the factors they were using to describe whether or not it was an effective surgical intervention or not. So in that respect, I do agree. There's too many surgeries that aren't needed of osteoarthritis, arthroscopic surgeries. But that hasn't seemed to, telling orthopedic surgeons that you don't need to be doing those hasn't seemed to reduce them. They're still doing them. It's just like when doctors were giving prescriptions for antibiotics for people that had viral pneumonia or whatever, and they told the clinicians, you're causing more multiple resistant organisms to hang around, more bacteria that are resistant to more antibiotics, because you're giving antibiotics for things that aren't caused by bacteria. And the clinicians were getting the same pressure from patients. I want a prescription, so they give them a prescription. I guess kind of like the old Jewish saying about chicken soup, as far as somebody that's sick. Well, it couldn't hurt. But what can hurt is telling someone who has a serious knee problem. The knee is worn out and they're in a lot of pain. Say, well, I'm not giving you painkillers, I'm not giving you anti-inflammatories. I'm telling you to go home, lose weight, and exercise. Weight-bearing exercise is going to put more torsion, more shear forces on a joint that's already worn out, and accelerate the wear and tear of a joint that really needs to be addressed, possibly with surgical intervention. I agree that surgery should be the last exit on that train, that you ought to stop at every potentially useful conservative care method, but you don't need to avoid it completely if it's what's indicated. And also, they were basically saying there's too much imaging going on, and I don't know if I can be able to jump to it right off the bat. They're saying that based on current guidelines, I'm quoting, imaging should be reserved for instances where a diagnosis is unclear, and radiography could rule out other diseases that produce similar symptoms. Research studies estimate that there are 95 million high-tech scans, that's CT, MRI, and PET scans, done annually in the U.S., representing a $100 billion industry, of which $14 billion has been shouldered by Medicare, and 20 to 50% of these scans were unnecessary as the results failed to help treat or diagnose the patient's symptoms. Well, look, for example, if you believe from your clinical evaluation that a patient has a complete tear, rupture of the supraspinatus tendon in the case of rotator cuff problem, the only way you're going to get approval for surgery is to demonstrate on film, on imaging, that there's a complete tear of the supraspinatus tendon. Just your clinical findings are not going to get the powers that be in the insurance company to authorize surgery, and often it won't even authorize an orthopedic consult. So you have to do the MRI imaging as the gold standard to get people to let you go forward in the care for the case. That's something I know from being a doctor since 1989 for 25 years. Also, if there's a knee problem, you need to demonstrate. You can take an x-ray. It's not going to show you whether there's a bucket handle tear or a soft tissue, the meniscus is gone, whatever, or lateral collateral tears or whatever, ACL, needing ACL repair. You need to do the imaging to demonstrate there's a good reason to have an orthopedic consult and to do surgery if it's indicated. So I find this completely irritating. It does a disservice to patients, causing them to, in the case of telling them go home and, since you haven't done the MRI, go home, keep running on that bad knee and lose a few pounds and everything will be hunky-dory. It's not going to be hunky-dory. If the knee's worn out, it's worn out. You can exercise till you die and it's not going to fix it. You can exercise till you're in so much pain you can't go to work. You want to scream at your kids. It ain't going to fix it. And truly, one of our problems in the United States is people are taking suicide as the way out a lot of times. And we know that clinical depression often results from chronic pain, which is pain of 6 months or more. And if you lose your job because you can't work because your knee's killing you and you can't walk, you can't climb the ladder, you can't do whatever, and you're in so much pain you can't run with the kids, play ball, whatever, too many people already are killing themselves. If a patient comes to you asking for relief and help, and your effort to help them is basically go lose a few pounds, you lazy guy or gal, and it's not helping. You're doing them a disservice, and it aggravates me because it all boils down to the less is best. Don't do this, don't do that for them because we don't want to pay money out. And we've done studies that we're going to call medical evidence, best practices, evidence-based guidelines, whatever. So that's my rant for the day. If you're a practitioner, you probably understand what I'm saying. If you're a patient, you probably understand what I'm saying. And if you work for an insurance company, I'm sure you're irritated by my video. But, I don't really care. Anyway, today's May the 2nd, 2014. What I do care about is patients. And we put the care back in healthcare. We put patients first at Baker Chiropractic. So if you're hurt on the job, hurt in a wreck, or you're just hurting, come to Baker Chiropractic. See if a drug-free health management system might be able to give you some relief. And if you've been on drugs and you're sick of being on drugs and it's not helping, drugs never fixed structural issues. Painkillers can help with the pain up to a certain point, but if you've got misalignment of the spine or the joints are not functioning properly, you can take painkillers and anti-inflammatories till you throw up. You're still not going to fix anything. So it's better to work on the cause of the problem, but you shouldn't ignore the symptoms either. And I think basically that paper they were saying ignore the symptoms and do anything that you can that won't cost insurance any money. So have a great day. I hope you enjoy the weekend. Appreciate every time you watch my videos. Take care. Bye-bye.